I have no disclosures other than not really interested in becoming a center of excellence for malignant large bowel obstructions. I try to keep these simple. I appreciate it when speakers keep the outline simple. So background, when to divert, when to resect, when to stent. I also really appreciate it when people get to the point so I can go back to checking Twitter. So when to divert, rectal cancer, or if the thought seriously crosses your mind. When to resect, I'll say if the stars aligned, it's okay to do an anastomosis on the right and think twice about it on the left. And when to stent, it's a good option for the palliative setting. On the left, as a bridge to surgery to avoid a stoma. This is often talked about and less often done. So as a background, 8 to 15% of new colon cancers present with obstruction. These are big bad tumors in fairly sick people. There's a 7 to 15% 30-day mortality when you look at population studies from both the U.S. and the United Kingdom. That's pretty high. Obviously, the big risk factors are age, ASA score, and the overall urgency, whether this is something that can wait a day or if it's something that needs to go urgently in the middle of the night. So you really have two goals, to relieve the obstruction and to treat the cancer. And my tips for this are to, number one, keep your options open. And number two, don't let your solution to goal number one mess up your solution to goal number two. So when to divert? As I said, rectal cancer. By its nature, the treatment of rectal cancer, as Dr. Chang talked about, and I think others will, is multidisciplinary and multimodal. And when the patient's suffering from a bowel obstruction, you don't have 9 months to treat with neoadjuvant therapy and then relieve their obstruction 9 months later. You have to relieve that obstruction now and then get your team together and assess as you normally do for your oncologic treatment of the rectal cancer. Colon cancer, that's going to require a multivisceral resection. I think about the sigmoid that's involving the bladder or the ureter. 8 o'clock on a Saturday is probably not the time to start doing a lot of big multivisceral resections and on block right colectomies with a Whipple or a right hepatectomy. But it's usually not my Saturday. Palliative setting that's also not amenable to stenting is when I think about diverting. So what are your options for diversion? Good old loop transverse colostomy, right? The good of this, it's pretty easy. You can do it through a upper midline incision. It's not too difficult to do even when the bowel is pretty dilated. It preserves the left colon as an anastomotic conduit for later surgery. The bad, this is basically a smelly ileostomy that prolapses. Patients don't love it, but it gets you out of a tight situation. You can also do a loop or end loop colostomy of like the sigmoid. What I mean by that is I bring up the sigmoid, I divide it, the proximal side becomes end colostomy. I bring the corner up of the distal side and mature the corner as a mucus fistula, but you can put that all in the same trephine. If you have an obstructing rectal cancer, very, very low that is going to be an APR. Ideally, anything that's going to be a permanent colostomy, you'd like to have marked by an ostomy nurse preoperatively, and that sometimes is not always available in an urgent setting on evenings and weekends. So when to resect? This is going to be the stable patient or conversely, the very unstable patient. So when I think about the stable patient, if you really are in a situation where the obstruction is, we have to operate for obstruction, but the tumor is amenable to an adequate oncologic resection and the patient's stable, go for it. Conversely, if the patient is very unstable and you're dealing with dead bowel or there's a perforation at the tumor site, obviously you're going to need to be resecting. Think also before you venture to a resection, what risks you're taking on and what are the postoperative risks. Oftentimes, by definition, obstructing tumors are advanced tumors. Many of them will need adjuvant therapy. And are you putting the patient at risk for a risk that would compromise their ability to get that adjuvant therapy? So to that end, do you do anastomosis or not do an anastomosis? The data would suggest that you can accept 1 to 2% leak rate on the right side. I would say 1 to 2% is maybe a little high compared to our typical elective setting, but it certainly is less than the risks incurred by an endoleostomy. Obviously, the patient has to be stable from a physiologic standpoint with adequate nutrition and all those other things that go into making a good anastomosis. On the left side, there is some data that this can be done. I would say watch out for mismatch of the bowel lumen. Also, the data would support that you should do an on-table lavage to decrease the stool burden. Probably on the left side, more commonly done is the Hartmann's resection. The Hartmann's resection was actually described for cancer. I think we think of it as a treatment for diverticulitis, given the relative frequency of diverticular disease versus obstructing left-sided cancers. Obviously eliminates the concern for leak. And then subtotal colectomy. It's mostly done for multifocal tumors or if there's concern for bowel ischemia or necrosis. Obviously, you're committing the patient to an endoleostomy most of the time, or if you are taking them down, there's the subsequent change in bowel function that comes from a subtotal colectomy. And then finally, everybody's favorite topic to talk about and never do, stenting. So when to stent? So I think of stenting like Kirk Cousins. You got good Kirk Cousins and you got bad Kirk Cousins. And Kirk Cousins is the quarterback for the Minnesota Vikings. And if Kirk Cousins is playing in the day, not at night, and against a bad team, he's going to look like a Hall of Famer. And if he's playing against the Packers or at night, he's going to look awful. And that's what stenting's like. If the stars align, it's going to look great. So it's got to be left-sided, ideally not in the rectum. You deploy that stent in the rectum, they're going to get a lot of tenesmus. And please do not radiate a stent. I have spent too many hours fixing that. Or if it's a palliative scenario, when you're considering a fairly limited life expectancy, or as a bridge to surgery, and if there's curable disease. So I think I don't have any gastroenterologists at my institution that are real interested in this, and frankly, it's not a situation that comes up with enough cadence that I felt like I could get my skills to where it's at. But just some technical considerations. First of all, if you have to be pretty adept at doing endoscopy and fluoro at the same time, so it's usually your interventional gastroenterologists who do a lot of things like ERCP and stuff like that. I know there's some very talented folks here at the university that do that, and so often when we think we have a stenting candidate, we transfer them here. You're looking for a 2-centimeter overlap. Boston Scientific wall stent, just an example. Yes, I'm driving a new Tesla. No, they didn't pay me to say that. But is a 22 to 25 millimeter diameter, and it comes in various lengths, 60, 90, 120 millimeters in length. And these are uncovered metallic stents. And so, when you're looking at these series of stenting, I think the main takeaway is that these are groups that are highly motivated to do it, and even they don't see it kind of all that much. So this is a retrospective review of a prospective database of 12 years, and over 12 years they had a whopping total of 100 patients, so that's 8 patients a year, and 26 of them had curable disease, so 2.2 patients per year that were a bridge to surgery. They do have excellent success rate. I think that in the right patient, you can be confident that the success rate will be high. Overall, fairly acceptable complication rate with 1 perforation. They had a 31-month mean follow-up. They had 13 deaths, 18 directly due to cancer. Some colleagues from Japan. It's a multi-center prospective observation study of 426 patients. Excellent high technical success rate of 98% with a high clinical success rate. 1.9% complication rate, or perforation rate, and 1.2% stent migration rate. And so I saw that actually kind of countered my my prior, I would have thought stent migration would have been more of a complication than perforation, but they actually reported a fairly lower. This isn't one of the largest series that I could find. So I think that may just speak to their technical expertise. 92% were able then to proceed as a bridge to surgery with a primary anastomosis to avoid a stoma. They had a 3.8% anastomotic leak, not bad. 10% overall stoma rate because they did do some protecting ileostomies. They had a 17% overall complication rate and a fairly low mortality for a group of patients that historically has had a high mortality. So the question then is, do these have similar outcomes? Are you burning an oncologic bridge by doing a stent? And again, with the caveat that these are not randomized trials taking similar patients and randomizing them to different techniques. You're taking one highly select group of patients and then doing some propensity score matching to match it to a more traditional group of patients. But a group in Seoul, Korea found that there was no difference in disease-free survival or overall survival. And I believe that was at 3 years. So in conclusion, resection, diversion, and stenting are all options for the malignant large bowel obstruction. It's unfortunately common and carries high, and these are high-risk cases. You have two goals: relieve the obstruction and treat the cancer, and keep your options open. It's okay to do a primary anastomosis on the right. Think twice about doing it on the left, and do an on-table lavage if you do. Strongly consider diversion for rectal cancer or unresectable colon cancer. And stenting is also an option with excellent outcomes in highly selected patients. And I thank you for your time.
One question I have for you is, what do you do for the patient with, unresectable disease that shows up? Do you stent? Do you divert? They're obstructed, but they have unresectable disease.
Unresectable,
but a malignant large bowel obstruction.
Yeah, I tend to divert that. If it's right-sided, a loop ileostomy, and I may intubate the distal limb to relieve because if they have a competent valve, you got to worry about that issue, or a loop ileostomy with a right-sided mucus fistula. But yeah, in my hands, stenting, I think, again, though, there's very good data, those unresectable tumors, if they also have widespread metastatic disease, that's likely a purely palliative situation, and the data on that is that you can stent them and not have other bowel-related issues that you have to worry about down the road. Dr. Chang?
So, thanks. That was a great review. So there were two randomized trials, the Dutch Stent In and then the Dutch Stent In 2. So Stent In was a malignant bowel obstruction, which closed prematurely due to stent-related complications. And then Stent In 2, which was a bridge to surgery trial, which also closed prematurely because of stent-related complications. And so I'm just curious to hear your thoughts on sort of this. You were much more enthusiastic, I think, than I would have been about stent as bridge to surgery, and maybe you can just kind of, put that in perspective.
So this is the trouble with being the young guy in the senior. I have to say, I'll just confess my ignorance. I'm not aware of those trials or the data surrounding them, but thank you for bringing them to my attention.
Quick question. I want to make. Did you say you'd recommend not radiating a rectal stent?
Yes.
That's interesting. we do a lot of that, and it's been okay. We've had trouble with giving Avastin with a stent and having perforation from an angiogenesis inhibitor, but some neoadjuvant radiation and then going on to surgery after that has been okay for us, I guess.
Yeah, and I have to say that's just purely from experience. I don't have data to support that. Dr. Chang? Yes.
If you don't mind.
I do not, please.
No, actually, I think, the comment you made about, I think in answer to Dr. Larson's question about what to do with these patients, right? Probably the horizon has something to do with the decision, right? If you know that if we can probably assume about a 6-month lifespan for one of these stents, and so if a patient who presents de novo, we can anticipate in the modern era close to a 30-month median survival. That's probably a patient that if you stent them, you're going to have to keep working on that patient, and so I think your option for diversion makes a tremendous amount of sense. But somebody who presents late in their disease course, then they've got all kinds of disease. I think that probably is a totally different scenario. And so maybe a much better option in that setting to think about.
Thank you.